So without wasting any time, we'll move on to the scientific papers for the day.
Yeah. Thank you again. Thank you for having me as the judge.
The first paper of the day presented by Dr. Nikitha. And the moment you see an answer like grade 2 is environment and disarticulation. But here, the usual thing, instead of disarticulation, they tried a fillet pad. And this is what the paper is about. Fillet pad, the toe Saviour, presented by Dr. Nikitha. Over to you, Doctor. Judges, please note, there will be 8 minutes, 7 minutes will be well, 1 minute afterward it will be 8 minutes, 2 minutes, plus or minus 1 for each.
Good evening, everyone. Today my paper is about fillet flap, the toe Saviour. Speaking about toe ulcers, the most common thing that is done for toe ulcers are toe amputations. And nowadays, toe amputations are being done so frequently, especially in this era of rising incidence of diabetes. Though this procedure is the right thing to do, this inevitable loss of the toes are causing so much complications for the patients in both physical, economical, and psychological aspects. So toe amputation is a minor surgical procedure, but there is a historical view that it is a first stage in a predictable clinical course leading to eventual limb loss. So the overall most common cause of toe amputation is diabetes. Some of the other causes of toe amputation are peripheral vascular disease, trauma, chronic infections like osteomyelitis, tumors, nail deformities, and congenital anomalies. So usually after amputation, the wound is left open and allowed it to heal by secondary intention. It usually takes a long time to heal, and the chance of recurrent infections are also high, which adds to further hospitalization and cost. So to prevent all of this, various methods have been introduced for the coverage of defects after amputation. There's skin graft, free tissue transfer, local flap coverage. So fillet flap is a type of local flap coverage, and by definition, they are axial pattern flaps that can function as composite tissue transfers. So they can be used as pedicle or free flaps and are useful for reconstruction of certain defects. So now we would like to share our experience with the fillet flap. So our aim is to assess the outcomes of fillet flap procedure in infected toe ulcers with or without osteomyelitis of bone in a place of amputation. So our study was carried out in the Department of Plastic Surgery, St. Martha's Hospital, from January 2021 to December 2021. We did an analysis of 10 patients who underwent fillet flap procedure for toe ulcers. So all our patients were preoperatively evaluated with routine investigations. Diabetic evolution was also done if the patient was diabetic. Vascular status was all assessed. And after proper informed consent and all the risks and complications were explained to the patient was taken up for the fillet flap procedure. So this is a diagrammatic example of how we did a grade 2 fillet flap. So all the infected tissues were removed till the ulcer level, and all the dividal tissue was removed, and the bone, the distal phalanx and some part of the proximal phalanx was removed depending upon the osteomyelitis of the bone involved. And then whatever the remaining viable tissue was left, it was created as a flap, and the defect was covered using a plantar based flap or a dorsal based flap. So the results of a study among 10 people, most of them were males with a mean age of 65 years and with a body mass index was 26 kilogram per meter square. And in our study, most of the ulcers were found in left leg. So all our diabetic patients with a mean glycosylated hemoglobin of 8.49, and all the patients had ulcer over the grade 2. So out of 10 patients, 2 patients had osteomyelitis of the distal phalanx bone, and the procedure was done under ankle block or spinal block, and the mean operating time was 45 minutes, and the average hospital days was 3.5 days, and the total time for complete healing was found to be 6.8 weeks. And after a mean follow-up of 6 months, all our patients were completely healed. There were no ulcer recurrences, and there were no complications like flap necrosis or flap infections. So among the 10 cases, we would like to discuss a few cases that we have done in our hospital. So the first case is a male patient who had a raw wound area with the plantar aspect of the grade 2. So for this patient, a fillet flap procedure was decided, and then all the devital tissue was removed, and the distal phalanx was removed, and whatever the remaining viable tissue was there was raised as a flap, and the defect was covered using an anterior based flap. So this is a picture of the patient on a post-op day 45. So this is a female patient who had ulcer over the left T1. She is already known diabetic patient and has a history of peripheral vascular disease. So as the same way as case 1, for this patient is also distal phalanx was removed, and the remaining viable tissue was created as a flap, and the defect was covered using a plantar based flap. This is a picture of the patient on post-operative day 42. So this is a case 3, who's a male patient who had a ulcer over the left T1. As in previous cases, for this patient also, distal phalanx was removed, and the remaining viable tissue was created as a flap, and the defect was covered. So this is a patient on post-op day 23. So coming to our discussion part, the key principle in plastic surgery for soft tissue defect coverage is a replacement of like with like. So this was called as spare part concept by Kunsher, which means using amputated or traumatized part of the limbs to cover the defects. So fillet flap is an extension of the spare part concept, and the indications are usually an ulcer associated with or without the osteomyelitis of same or neighboring toe. So unlike a random local flap, fillet flap always includes an axial artery with consistent vascular supply, even in those with diabetes and peripheral arterial disease. So we would like to emphasize some of the advantages of fillet flap. They are minimal bone resection and flap harmony with the surrounding soft tissue. These can be harvested very quickly without any donor site morbidity, and usually they don't require any microvascular anastomosis. Since web space architecture is being preserved, there is no collapse of the adjacent digits into the amputated space. And as we all know, the most of the weight bearing function is carried out by the metatarsal head. So hence by preserving it, it prevents the pressure transfer to the other metatarsal head. Hence we preserve the ulcer recurrences in the neighboring toes. So in our study, the mean time for the complete healing was 6.8 weeks when compared to Kunsher et al. Study, which was 10 weeks. So 18% complication rates were found in Kunsher et al. Studies, which was not found in our study till date. So we conclude by saying that fillet flap seems to be an attractive option for toe ulcers in place of an amputation. And the patients also are having a psychological improvement in them since they feel that their toes are being preserved. So we think that a study is a very inclusion of a very small case series, and we may think that we need a control group to compare with, and the long-term follow-up is also needed. So these are my references, and thank you.
Thank you, Nikitha. The paper is open for discussion now.
Yeah, Dr. Nikitha, Dr. Niranjan here.
Yes, sir. Yes, sir.
Yeah, novel approach, but I have two concerns. You said with or without osteomyelitis.
Yes,
So in the no osteomyelitis group, was the even if the wound is infected, you do the flap?
Yes, sir. Even with the patients who doesn't have osteomyelitis, we still remove some part of the bone to create a flap, and we used to cover it even without osteomyelitis.
Why not only debridement in those cases then? Because creating a flap, removing the bone, creating a flap in an infected setting,
Yes,
don't
sir.
you think that sepsis can worsen further, can extend proximal into the foot?
Maybe it depends
So how
upon
will you prevent
each,
that? And what is the purpose of doing a flap in that setting?
Maybe it depends upon the case. If the infection is like furthermore.
No, that's what. So what is your criteria? How will you decide? This case I will do a fillet flap. This case I will not do.
Sorry, sir. I'll just.
No, because you put up a paper and you're propagating fillet flap. No, so you should have a particular criteria that for this case I will do a fillet flap and for this case I will not. Where the risk of infection is more or something of that sort. Or you choose randomly.
maybe we'll see the patient has any other comorbidities like any peripheral vascular disease. If there is like if the chance of the flap survival, if it's very less, then we may not
No. Not about the flap survival. That is at the later stage. But my first concern is how you decide. For this case, I will do fillet flap. This case, I will not do. Or for all toe ulcers, you do fillet flap.
We randomly choose like most.
No, but there has to be scientific rationale. No, anyway, thank you.
Sorry.
And that depends whatever she said about the development, and then the exposed bone result have a soft tissue, for which she is going to let go. The sacrificing normal bone. That's what she is meant to say. And if there's no osteomer, that is a criteria. That's what she's saying. Otherwise, the osteomyelitis development, get the flap to cover the exposed bone, which doesn't have a soft tissue. That's what that's trying to say. Anyway, thank you.
Yeah. May I just interrupt? Can I just put in a few words?
Yeah,
I'm
please.
Dr. Rahul. Yeah, so a good question actually by Dr. Niranjan. Yes, if there's only soft tissue infection and no osteomyelitis of the bone. Hello?
Yes, sir.
Hello? Hello?
Yes, sir.
Yeah, so if there's only soft tissue infection and no osteomyelitis of the bone, then we look at what is the extent of the soft tissue infection? Can a flap be fashioned with the remaining viable tissue and used to close the wound? And if we find that the adjacent viable tissue is not sufficient to close the wound, then probably we would go for a total toe amputation. So the takeaway message is fillet flap is not for all wounds. So that's a good, very, very good question. There should be a sufficient amount of viable normal soft tissue with which we can close the stump. So that I think should be able to answer Dr. Niranjan's question.
Yes, sir. I got that. My concern was when there is infection and if you close the wound, is there not a risk of sepsis spreading further down the line, like proximally? So how do you prevent that, or how do you take that decision?
See, the first and foremost is we actually, like I already said, that we have to make sure that we have done a good debridement, and we have enough good viable tissue remaining. At the end of the debridement, if you feel that there is a chance that the infection still linger and fester, if you close the wound, then probably we wouldn't have gone for a closure of the wound.
Yes, sir.
So,
that's what my question was. So how do you decide on that part?
This case comes to us only after the debridement and everything is done, and then only we decide whether we need to go ahead and close, or maybe then wait for the infection to subside, whether we can really salvage the toe.
Okay, so
like you said,
you mean it has to be done in 2 settings?
Yes. We have to have clear
not in a single setting.
Yes. Sometimes we might need to do it in 2 settings.
Yes. Thank you, Dr. Rahul. Time is getting up. Thank you, Dr. Nikitha. It's a good discussion. Next go on to the next paper. Tuberculosis, as you know, is a very common condition what we present as surgeons. So Dr. Vijay is speaking about intestinal presentation of TB, its outcomes, and as an acute outcome. Over to you, Dr. Vijay.
Good evening all. I am presenting a paper about the intestinal TB, its presentation and outcomes as acute abdomen. TB is a disease that has been affecting the mankind since the time immemorial, and it still continues to be the most global health concern. And it affected around 10 million people, and or constituted around 1.5 deaths in the year 2020. The major causes which included poor living conditions, overcrowding, and limited access to the healthcare facilities. India has got the maximum number of cases that are affected by TB. When you look at the definitions, abdominal TB is a TB of GI tract and any other organ within the abdominal cavity, but excluding the esophagus. Intestinal TB is a non-peritoneal GI TB, whereas the tuberculosis of peritoneum is called peritoneal TB. Looking at the prevalence, extrapulmonary TB constitutes around 20% of all the TB cases. Out of these, around 12% are abdominal TB. And it's a disease which mainly affects the young adults. We look at the prevalence, and out of abdominal TB, GI tract, that is from mouth to anus, constitutes around 49%, followed by peritoneum, which is around 42%, then by solid viscera, 5%, followed by mesenteric lymph nodes. The most common site of involvement is ileum, followed by AC region, and followed by colon and jejunum. It has got varied presentations, ranging from acute presentations such as obstruction and perforation, as well as chronic presentations such as vagal health, anorexia, weight loss, subacute obstruction. Out of all the small intestinal perforation cases which attends the emergency, TB is responsible for about 5 to 9%. Due to abdominal TB has got is a great concern for surgeon because its early diagnosis is very difficult, and some of the patients may benefit from antitubercular therapy, while some patients develop surgical problems such as strictures and obstruction, which may necessitate surgical intervention. It has been a great concern for surgeon because when it presents as acute abdomen, a surgeon has to decide about the extent of the surgery in an acute setting. Coming to the objectives of a study is to study the frequency of the intestinal TB in acute abdomens, and to study the various modes of its presentation, and to study the different types of management. We included all the patients who had undergone laparotomy with presentation of acute abdomen, the patients who were diagnosed to have intestinal TB either by histopathology or by PCR, and all the patients are above 18 years. We excluded the patients with the pulmonary TB and the patients who had already been diagnosed with TB, and the patients below 18 years. This is a retrospective observation study conducted in our hospital over a period of 2 years, and all the 10 patients in our study were all adults. A careful history taking was done, clinical examination, as well patients were rapidly resuscitated in the wards, started on IV antibiotics, and routine investigations were sent. Out of 10 patients, 8 of our patients needed emergency laparotomy, and another 2 needed intervention after 24 to 48 hours. During the surgery, macroscopic appearance of the intestine, lymph nodes, as well as mesentery were suggested of diagnosis of TB, and intervention was done according to the pathology found, and the specimens were sent for histopathology culture as well as PCR. And in each case, TB was diagnosed, and the patients were started on ATT. After appropriate management, the outcome of each case is studied and is followed till date. These are some of the intra findings. We were first image showing the tubercles. These are stricture abdomen, and this image shows the multiple strictures. And this is the image of the intestine with multiple perforations. These are 2 images showing cocoon abdomen. Coming to the results of our study, out of 110 patients who presented with acute abdomen to our emergency and underwent laparotomy, around 10 patients were diagnosed to have intestinal TB, which constituted around 9.09%. And the most common age group presenting was 21 to 30 years, which is around 40 years. And almost 60% of our patients are below 30 years. And in our study showed a female predominance where 60% of our patients were females. And when looking at the clinical presentation, around 40% patients presented with intestinal obstruction, followed by perforation peritonitis in 30%, and then RIF pain, one patient in each, RIF pain, abdominal pain with lump, and with ascites. These are the images showing intestinal obstruction, perforation, and the first image shows the RIF mass where hypertrophic variety with ascending colon stricture where our white arrow mark showing ascending colon thickening, and the second image shows the abdominal cocooning. On investigations, around 60% of our patients were found to be anemic, and 80% of our patients had leukocytosis, and ESR was positive in around 80% of our patients, and none of the patients chest X-rays suggested TB. Looking at the site of the pathology intra-op, around 40% of the patients, terminal ileum was involved, followed by AC region in 2 patients, and proximal ileum in another 2 patients, and 2 patients had cocoon. Intra findings, stricture was most common and was seen in 30% of our patients. Hypertrophic variety in AC region in 2 patients, perforation in 2, cocooning is also in 2 patients, and only 1 patient presented with perforation with only tubercles. Looking at the management, that is a operational procedure executed, 3 of our patients underwent primary resection anastomosis, and another 2 underwent ileocolic anastomosis, and 2-stage procedure was done in 2 patients, and only adhesiolisis with ileostomy was done in 2 patients. Looking at the post-op complications, 60% of our patients had respiratory tract infection, 5 patients, 50% of our patients had wound infection, and 1 patient had anastomotic leak, and we saw 2 deaths in our patients. Looking at the follow-up, out of 4 patients underwent ileostomy, 2 patients underwent ileostomy closure, and they are doing well. All our patients were started on ATT. 2 of our patients faced death. 1 patient came back with the symptoms of SIO. Coming to the discussion, out of 110 patients who presented with acute abdomen and underwent laparotomy, around 9.1%, that is around 10 patients were found to be suffering from abdominal TB. And this result are similar to a study by Mukhopadhyay et al., where the prevalence was seen around 10%. And our study showed a female predominance, and the common age group was 21 to 30 years. And this can be told as it's a disease predominantly affecting the young females at an early age group, just similar to the study by Sharma et al. Almost all our patients, that is around 90% of our patients were from low socioeconomic group. Looking at the presenting symptoms, abdominal pain was seen in almost all the patients, and 6 patients, or 60% of patients had vomiting, and 40% of them had abdominal distension, which are similar to the study by Cho et al. The study from India in the last 3 decades has shown that the most common presenting symptom is 80 to 100% of our patient was abdominal pain. On laparotomy, the predominant site of involvement was terminal ileum, followed by AC region. And coming to the management, choice of the surgical procedure will depend on the site and the extent of the disease, status of the gut, and the general condition of the patient, as well as the surgeon's choice. But in a considerable number of cases, which were complicated with fecal peritonitis and intraabdominal sepsis, 2-stage procedure was done. And post-op around 10 to 12 weeks after ATT, stoma reversal was done, and patients are doing fine. Looking at the post-op complications, most common complication is a respiratory tract infection, followed by wound infection. However, 2 of our patients had septic shock, MODS, followed by death. To conclude, abdominal TB is a disease with common disease with uncommon presentation, constituting a significant percentage of all the cases which attend the emergency with acute abdomen. And abdominal TB is often difficult to diagnose because diagnosis is often delayed due to its vague presentation. But to conclude, any young patients who are cachexia and presenting with acute abdomen and radiological investigations such as TB, it's better to undergo surgical procedure rather than conservative treatment because of its associated morbidity and mortality, as seen in our study. Thank you.
Thank you, Dr. Vijay. The paper is open for discussion.
Dr. Vijay, there are 2-3 questions. One, what were the indications for ileostomy?
The question is from Dr. Vijay. Vijay, yeah, question?
Yes.
Causes for the mortality.
As for mortality,
Patients have died.
2 of our young patients, one, the presentation was after 15 days of their symptoms starting, sir, and the general condition was too poor. So they were in the stage of sepsis when they presented. So even after post-op, the general condition. Perforation, sir. Perforation followed along with that, cocoon abdomen was there. So even intra was also quite difficult.
Can I talk to you, please?
Finding when you open abdomen and say this is
I can't hear you.
the most common macroscopic appearance when you open an abdomen and say this is TB abdomen.
Most commonly, tubercles are seen over the intestine and peritoneum.
Can I talk to you, please?
Hello,
Yes, sir.
Dr. Vijay.
Yes, sir.
Yeah. What were the indications for ileostomy? One question. First question. Second, what is the take-home message from your paper for the audience?
One, the indication of ileostomy was patient's presentation was the patients were in septic condition with the bowel condition was too poor in them with multiple tubercles of friable bowel and with perforations. We did ileostomy for those patients, and the patients who had
was
low protein.
ileostomy was done only for perforations or for something else?
Perforations and with cocoon abdomen.
Cocoon abdomen, why did you do ileostomy?
In the terminal ileum cocooning, with friable bowel, we did ileostomy in the proximal.
No, but why do you have to do ileostomy? Friable bowel, how will you decide? If there is any obstruction, then there is a point in doing ileostomy.
So there are some defined conditions when you do surgical intervention in TB abdomen. Dr. Niranjan wants to know.
Other than perforation, what are the indications for ileostomy? Not cocooning is not an indication for ileostomy.
Yeah, one stricture patients where the patient protein levels were low, resection anastomies along with ileostomy was done in this.
No, but in those stricture, did you evaluate preoperatively whether it is a partial stricture or complete stricture?
CT was done, sir.
So when did you decide to do ileostomy?
Ileostomy was done.
When
Patients
there is
with
partial
fecal-
stricture also you done ileostomy or?
Partial stricture, we are not done ileostomy, sir.
Okay.
Complete
What is the
obstruction.
take-home message? What is the take-home message from your paper?
Take-home message is any young patients who are presenting with acute abdomen, that should high suspicions of TB should be considered. And rather than waiting, even if the CT shows a partial obstruction, it's better to undergo a surgical procedure rather than doing conservative management.
Partial
Because-
stricture also, because you yourself said you don't have to do anything for partial stricture.
But in a young cachexic patient where their general condition is poor,
So in all the more so you don't do a resection procedure in them.
if
You yourself is like contradicting your own statements.
if we wait on them, as seen in the intro findings, it's difficult to operate in a friable ball rather
No,
than
you don't have to operate for partial strictures. If you're telling
partial
that you
obstruction.
partial obstruction also, they can take liquids, they can start ATT. When the patients are sick, you can optimize their nutrition.
If the
Why do you want to
CT
do a
is showing
resection
a-
procedure?
if the
Can I
CT
talk to you?
Yeah.
Can I talk to you, please?
Yes, sir.
No, I've got 4 points. Very interesting case of tuberculosis. Can you hear me?
Yes, sir.
Please do not forget inflammatory bowel disease when you are managing tuberculosis.
Yes, sir.
Time and again, we get into trouble because it has been treated as tuberculosis.
Yes, sir.
Always keep a mind on IBD and rule out especially Crohn's ileitis and Crohn's ileocolitis.
Yes, sir.
Do not rely much on our intestinal biopsy because our intestinal biopsy is mucosal and partially submucosal. We need a full thickness biopsy. I will be happy if you can consider a mini lab and take a full intestinal sample for histopathology. Number 3, laparoscopy is an underdiagnosed procedure. Encourage your medical trainees, medicine department to subject their patients to laparoscopy because it's going to give a first-hand information. As far as strictures are concerned, whenever you have a partial stricture, be very careful. Rule out where exactly is the stricture, how many strictures are there, because I'm sure you will agree with me. Once you start ATT, they heal by fibrosis. A partial stricture can become a complete stricture. That's all I have to say.
Thank you, sir. Dr. Patel, the points well taken, sir. The time is getting up. It's already 30 minutes. Thank you, Dr. Vijay. Thank you. We move on to next paper. You know, abdominal hernia, the care of the abdominal hernia, various mesh blast, everything is there. Now, Dr. Sai Prasanth will talk about an Etep and Ipom. It's our experience in the hospital. Take on.
Good evening. My topic for today is to share our experience regarding 2 laparoscopic ventral hernia repairs, that is Etep and Ipom, and their comparison. Ventral hernias are defined as the protrusion of bowel, fat, or fibrous tissue through a defect or a weakened region of the abdominal wall. Based on etiology, European Hernia Society divides ventral hernias into primary or congenital hernias and acquired hernias. These hernias can be treated either by simple closure of defect or by the use of prosthetic materials in order to reinforce the defect area, like meshes. When we talk about mesh, the next question arises is where to place the mesh. Different techniques of mesh placements include onlay, inlay, and sublay, which are shown in this figure. Open approach was the treatment of choice for ventral hernias till 1993, and among open approaches, Rive-Stopper technique is the gold standard technique. Open repairs are associated with resection of wide areas of soft tissues and are associated with wound infections and wound-related complications. Laparoscopic approach was introduced by to ventral hernia repairs first by LeBlanc and Booth in 1993 in order to avoid these complications of open repairs. Ipom seems to be the most widely adopted technique, but it is not useful for larger defects and is associated with complications such as prosthetic erosions, intestinal obstruction, acute and chronic pain. In order to avoid these complications of Ipom, other minimal invasive techniques such as transabdominal preperitoneal approach, totally endoscopic sublay repair, amylose, scola, and Etep were introduced. Among these techniques, Etep seems to be gaining popularity these days. When Etep technique is combined with the Rice-Stopper surgical steps, it is called as Etep-RS. Now, our study is to compare this new technique, that is the Etep-RS, with the widely used Ipom surgery. Our aim of the study is to compare this Etep-RS and Ipom techniques in uncomplicated ventral hernia repairs. We included all the patients with uncomplicated ventral hernias with a defect size between 2 to 5 centimeters and excluded patients who are not fit for general anesthesia and has a defect size of greater than 5 centimeters. We did a prospective comparative study from January 2020 to December 2020. Randomization was done by odd-even method, and association between variables was analyzed by using chi-square test for categorical variables and unpaid t-test for quantitative variables, and level of significance was set at 0.05. After dividing the patients into two groups, the following parameters are compared, which includes operative time, cost of the procedure, and post-operative complications. These are some of the pictures depicting the intraoperative steps of the Ipom. The first picture shows the defect with the omentum as its content, and the second picture shows the defect with oment after reducing the omentum. Here we can see that the defect is covered by 12 by 12 centimeters composite dual side mesh and is fixed by transfacial sutures. Followed by the mesh is fixed by absorbable tackers at its margins. Whereas coming to the steps of the Etep-RS, preoperative marking is done of subcostal margin, linea alba, linea semilunaris, and the hernia, which acts as the boundaries of the dissection. These are the various port placements, and a 10 mm incision is given at the left subcostal region, medial to the linea semilunaris, and a 10 mm port is placed in the retrorectus plane. After creating an adequate plane in the left side of the retrorectus plane, the most important step, that is the upper crossover from the left to right, takes place. After creating a sufficient plane on either sides, the hernia is identified and the contents are reduced into the abdominal cavity, and the hernia defect and the midline is reinforced by sutures in a continuous fashion. After reinforcing the midline, a large mesh, that is 15 into 30 centimeters polypropylene mesh, is placed in the retrorectus plane. Coming to the results of our study, out of total study population of 30, 15 patients are in Etep-RS group and 15 are in Ipom group. Mean age of patients in Etep-RS group was found to be 49.5 years, and in Ipom it is found to be 46.8 years. Mean defect area was found to be more in Etep-RS group when compared to Ipom. Mean duration of surgery was significantly more in Etep-RS group when compared to Ipom. Patients in Etep-RS group had a short hospital stay of 2.5 days. Whereas coming to the cost of surgery, the cost of Ipom surgery seems to be significantly more when compared to Etep-RS. Patients in Etep-RS group are more comfortable in terms of postoperative pain, which can be suggested by these pain scores. Hematoma and seroma formation seems to be more common in Etep-RS group, and one recurrence was seen in Ipom group. And one patient got readmitted with the features of subacute intestinal obstruction in Ipom group. Out of 15 patients in Ipom group, 6 patients had chronic abdominal pain for a period of 1 to 1.5 months and was managed conservatively with oral analgesics. Coming to discussion, the main objectives of open technique of ventral hernia repairs include reconstruction of the wall by restoration of continuity of the aponeurosis, tension-free closure, and the placement of the mesh. Minimal invasive methods which are being used now should meet these objectives of open surgery. When compared to other laparoscopic techniques, one pillar of Etep technique is the restoration of the midline. Coming to the benefits of Etep-RS, it avoids foreign bodies in the abdominal cavity, no transfacial fixations are required, and it also has a combined advantage of sublay position of the mesh and minimal invasiveness of the procedure. Etep-RS is not suitable for large and complex ventral hernias, and the procedure is extremely difficult in multiple small defects, and it has a long learning curve. In our study, we found that the duration of surgery was longer for Etep-RS group when compared to Ipom. Hematoma and seroma formation was more common in Etep-RS group. Hospital stay was shorter in Etep-RS group when compared to Ipom. Patient in Ipom group required analgesics for a longer periods of time when compared to Etep. Cost of surgery of Etep was found to be half the cost of the Ipom. One recurrence is seen in Ipom group, and one patient got readmitted in Ipom group with the features of subacute intestinal obstruction, who was managed conservatively on postoperative day 29 of Ipom surgery. 6 patients had dull aching abdominal pain postoperatively in Ipom, which is not seen in Etep group. With this, I would like to conclude by saying that Etep can be considered as an effective alternative for Ipom, as it is cost effective and is associated with less postoperative pain and allows the patient to resume their normal activities very early. But it has long operative time and it is technically challenging. We would like to increase our sample size and increase our follow-up period. These are my references. Thank you.
Dr. Prasanth, this is Dr. Niranjan here. Nice paper, well presented.
Yes, thank you, sir.
Yeah. How long did you follow these patients up?
Actually, mean follow-up was about 6 months, sir.
Okay.
And because of that only, we can't comment on recurrence yet.
No, I'm not talking about recurrence. You mentioned somewhere that chronic groin pain.
Chronic abdominal pain, sir.
Sorry, chronic abdominal pain. Okay.
Yes, sir.
What is the definition of chronic abdominal pain?
Chronic abdominal pain.
When do you consider the pain as chronic?
More than one to one and a half month.
No, it is around 3 months. Okay. Up to 3 months after the pain is persistent in cases of hernias. Yeah. Okay, nice presentation anyways.
Dr. Prasanth, am I audible?
Yes, sir. Dual mesh was used.
Oh, am I audible, Dr. Prasanth? Hello?
Sir, out of 15 patients, only one patient got admitted, sir, with subacute obstruction. Because post-operatively, only one patient came with obstruction. Maybe that maybe due to adhesion or anything. We didn't evaluate. We just managed him conservatively. We thought if he worsens, we'll get a CT and find out the cause. So since he settled, we never got to do a CT and find out the main cause of obstruction. A plus, sir? No, sir.
Prasanth, can I ask you a question?
Yes, sir. Yes, sir.
Now, is it Ipom done or Ipom plus? Do you know the difference between?
Yes, sir. Ipom is just Ipom plus is where we will close the defect. Here in this paper, we just did Ipom, sir. We didn't do Ipom plus.
Okay, Ipom will have more problems if you don't close the defect. Midline defect closure is most important in the Ipom when you are doing Ipom. Other question is, what is the training received by the surgeon before starting the Etep RS? You said there is a long learning curve.
Yes, sir. First, we started with the total extraperitoneal repair, which is done for inguinal hernias, which we extended it and did an Etep, extended total extraperitoneal. After that, we started training for Etep RS, sir. Initially, the operating period was long, which suggests that it requires a long operating period. But as of recent papers, there are many places where they will do the surgery in 160 minutes, whereas in our study it was about 189 minutes, which was more. So with that operating time and this one, I would like to say it needs a long learning curve.
Right. Thank you. Good paper.
Okay, sir. Thank you, sir.
Dr. Prasanth, am I audible?
Yes, ma'am. Yes, ma'am.
Yeah, I just missed it. How did you fix the mesh?
Mesh was fixed by 4 transfacial sutures, ma'am, and followed by a 10 to 15 absorbable tackers we used.
Tackers also?
Yes.
Do you need tackers also?
According to literature, it is better if we use them, ma'am. I mean, I know they are associated with pain.
Prasanth,
but
I think madam is asking for Etep RS, not Ipom.
Etep RS, no, ma'am. Etep RS, we didn't use any fixation things, ma'am. We just placed the mesh in, we created the plate and we just placed the mesh in the retrorectus plate. That's it.
You didn't encounter any mesh migration?
No, ma'am. As of now, no, ma'am. 6 months follow-up. As of now, we couldn't find any.
Because if you are waiting for a smaller defects and the space is more, there can be a mesh migration. So
Yes.
at least one transfacial fixation will be, 1 or 2 fixation will be better.
Yes.
Just
Okay. We'll take that into consideration.
Yes.
Prashant, in Etep, did you close the defects?
Yes, sir. Yes, sir. We closed the defect along with the restoring the midline. Linea alba also we closed if the patients had diver.
You close the peritoneal defect as well?
Yes, sir. Yes, sir. Peritoneal defect also we close.
Okay.
Yes.
Dr. Prasanth.
Still, the conclusion is, whether this is better, that is better, we don't know, we need some more.
Sir, that's what, sir.
You can't conclude with only just the 10 questions. You should have given some international.
Yes.
Numbers.
Okay. Okay. Yes, sir. So that's what our limitation also, sir.
Dr. Prasanth?
Yes, sir.
Yeah, I'm Dr. Sajid Nair here.
Yes, sir.
Yeah, have you anytime tried, any of you tried TARM technique for the same thing?
No, sir. We are yet to try it, sir. We'll try it in the future for sure.
Just
Yes,
for little knowledge, I would like to ask, do you know what is a Venetian slide technique?
Sir?
What's a Venetian slide technique?
Sorry, sir. I don't know.
Okay, you should read up. It's related to associated. You've never heard of it? Anybody else would like to answer?
Thanks.
Good evening, President and Secretary. I'd like to take this opportunity to thank you and the Surgical Society Bangalore for giving us this opportunity to present our papers. I'd also like to thank the General Surgery Department and the Faculty of Marthas for providing all the help in letting us reach here. Thank you, sir. I'd like to start with my paper. It's on the outcomes of pyeloplasty in pediatric PUJ obstruction. PUJ obstruction is the most common cause of obstructive nephropathy in children, seen in 1 out of 1,500 live births, routinely screened on an ANC scan, which is done in the 2nd trimester. It is noted that boys are more affected than girls, and the lesions are seen more on the left than the right. As surgeons, we love to operate, but the decision on when to operate is very important, and this is based on the symptoms and the imaging studies that are done, basically the USG and the DTPA or the EC scan. The aims and objectives of my paper is to describe the indications and presentation of the children with PUJ obstruction and to also determine the safety and efficacy and outcomes of pyeloplasty in these kids. Materials and methods, this was a retrospective study. Study period was from Jan 2016 to December 2021. Data was collected from the OP records, from the IP records, operative notes, and through telephonic follow-up conversation with the parents. Study population was all those children who presented with the PUJ obstruction under the age of 15 to the Pediatric Surgery Department in St. Martha's. Evaluation of these children was done by ultrasound. In ultrasound, we mainly look for the AP diameter, the cortical thickness, and the presence of hydronephrosis. A DTPA scan was also done, which checks the function, drainage, and the differential function of each kidney. In this image, you can see the AP diameter being marked. The first image showing a AP diameter of around 11, and the second one, the one below that showing a AP diameter of 8. You can also see the central callicial dilatation. This is a DTPA image taken posteriorly. You can see that even after 30 minutes, there is stasis in the left kidney. This is a renogram image in which the curves are produced. The black curve shows a normal kidney, which has normal uptake and also normal drainage. The red one indicates an obstructive kidney or obstructed kidney, in which the uptake is normal, but due to the obstruction, the drainage is restricted, because of which there's a red line. The indications of surgery for these children, if any of these children present with symptoms, mainly recurrent UTI, pain in abdomen or mass in abdomen, if the ultrasound shows a serial increase in AP diameter and also shows the presence of cortical thinning, DTPA scan shows a reduction in the differential function and also an obstructed drainage curve. Management of these kids is done by an Anderson-Hines dismembered pyeloplasty, in which we dismember the area of the PUJ, the area of the obstruction. There is reduction of the renal pelvis. There is spatulation of the ureter and also watertight anastomosis. This is the site of the obstruction. You can see the dilated renal pelvis. This is post-dissection. This is post-anastomosis. The results of my study had a sample size of 20 children. Age ranged from around 1 month to 9 years. Weight was around 2.5 kg to around 36 kgs. It was noted that we had around 12 boys and 6 girls, and among them, 10 children had lesions on the right and the 8 on the left, and 2 were bilateral. The presentation of these children was 12 of these were diagnosed on an ANC scan. 4 was came with pain abdomen, 2 with UTI, and 2 were incidental diagnosis. Pre-operative imaging showed that maximum of these children had an AP diameter of 2 to 3 centimeter. 2 had AP diameter of 1 to 2, and around 7 had an AP diameter of more than 3 centimeter. DTPA scan, all these children showed an obstructed curve. Around 15 of these children had a compromise in the function. The differential function was less than 40. 3 of them had preserved function. 2 of them had a DTPA, score was more than 50%. This is actually a fallacy in the DTPA test, in which due to the gross hydronephrosis, there is overestimation of the function. And hence, the computer reads it as more than 50%. Approach for around 14 of these children, we went ahead with open pyeloplasty, and 6 of them we went ahead with laparoscopy. The mean hospital stay was approximately 3 days. Complications, intra-op, we do not have any complications, although post-operatively we had 1 case of leak which resolved on its own. The catheter and the drain was kept in situ for around 10 days. Post-operatively, an ultrasound was done to look for collection, and post that, the catheter and the drain was removed. We had 1 case of major leak. There was a major drain output, due to which on day 4, the child required re-exploration and redo anastomosis. Follow-up of these children, we can see that pre-operatively, all these children, the mean AP diameter was around 28 mm, whereas post-operatively, it came down to 18 mm. The improvement in DTPA, all the patients had good drainage post-operatively. Functionally, 15 children had an improvement in the split differential function. There's a fall in function of those 2 children who had a supranormal DTPA result. As you can see in these 2 images, the first image shows retention of, stasis of the urine, of the tracer in the DTPA, whereas post-operatively, both the kidneys are draining equally. Conclusion, most of the patients are identified on ANC scan and hence are asymptomatic. USG and DTPA scan are extremely important in the diagnosis and the decision to operate in a PUG obstruction. Pyeloplasty is a safe and effective procedure with good post-operative improvement. Due to routine ANC scan, the diagnosis and treatment of PUG obstruction is done at the right time. These are my references. Thank you.
President, can I ask you a question?
Yes, sure.
Yeah. Nida, Dr. Venkatesh here from BMCRI.
Yes,
again, pediatric surgery.
Good evening.
Yeah, good paper, man.
Thank
but
you,
see, whatever that supranormal function, more than 50%, that is due to, it's not a fallacy. There is obstruction, the kidney overworks against the obstruction. That's why it's supranormal. Okay.
Okay, understood.
The other thing is, I'll take that answer as easy. You know what is easy?
Yes, sir. That is a marker that we used for.
No. It's okay. I'll answer for that. It's okay.
So the full form, ethylene cystine, sir.
Ethylene dicystinate.
Okay.
Okay, that's a tubular agent. We no more use DTPA. I personally have done a study versus EC versus DTPA. Whichever shows obstructive in DTPA has shown clearance in EC. So we no more use DTPA.
Okay.
Only ethylene dicystinate or MIG. There are OH. There are plenty of good molecules are available for the last 15-20 years. DTPA is an old one. We don't do it. Especially we are in Bangalore. We have access to all the things. So DTPA, we no more do it. Probably this is a old study. You've taken that DTPA. Only EC is done. Okay.
Okay, understood. Yes, sir.
And you have any doubts on pyeloplasty? You did so many good cases. What stent did you use? You have never mentioned about double J stents, DJ stents in your study.
Yes, sir. We have, so that was actually depending on the surgeon and their preference.
Correct.
So according to them, we have put a DJ stent and some have not put a stent. So.
Okay. And see, any like we do it on 2 or 3 months of age and all. So we all do with a stent only. There the surgeon part doesn't come there. So 3 months old without a stent, you're not supposed to do. DJ stent is a must. Okay. Yeah, nice paper, man. Thank you.
Thank you, sir. Thank you.
Yeah, good evening. Nice paper and nice presentation. Just one clarification. Is this paper open for awards or? Like I wanted to know, are you a postgraduate or?
Yeah. See, being a president-elect, she is a general surgery candidate, posted in pediatric surgery. She is eligible. The MCH candidate is not presenting. The general surgery candidate. Nida, you are a general surgery candidate, huh?
Yes, sir. Yes.
So she is eligible.
Okay, sir. Thank you.
Yeah.
Thank you, sir.
Good evening, everyone. I would like to thank Surgical Society of Bangalore and St. Martha's General Surgery Department for giving me this opportunity. I am presenting a case of paper over evaluation of hyperbilirubinemia as a diagnostic marker for acute appendicitis. Acute appendicitis is the most common cause of acute surgical abdomen. Appendicectomy is the most frequently done emergency surgery. In spite of advance in the radiological and laboratory investigation, the diagnosis of appendicitis still remains a dilemma in diagnosis. The investigations which aids in the diagnosis of acute appendicitis are like blood investigations like elevated total leukocyte count and C-reactive proteins. By clinical and laboratory assessment by using Alvarado score, and radiological investigation, ultrasound is the most widely used investigation to diagnose the acute appendicitis, and advanced radiological investigations like CECT abdomen pelvis. In spite of the above investigations, there is no confirmatory laboratory marker for the diagnosing of acute appendicitis. Why there is hyperbilirubinemia or elevated serum bilirubin in acute appendicitis? That is pathophysiology for hyperbilirubinemia. Whenever there is acute appendicitis or appendicular perforation, this causes transmigration or translocation of bacteria, toxins, tumor necrosis factors, cytokinins, interleukins. This leads to endotoxemia or bacteremia. Then, through the inferior mesenteric vein, this bacterial invades the hepatic parenchyma, which alters the physiology of biliary excretion, which causes hyperbilirubinemia. Coming to the aims and objectives of my study, I would like to correlate serum bilirubin level in appendicitis, appendicular perforation, and recurrent appendicitis to study the relationship between hyperbilirubinemia, acute appendicitis, and to evaluate its usefulness as a diagnostic marker for acute appendicitis. To evaluate whether elevated bilirubin level have a predictive potential for the diagnosis of appendicular perforation. My inclusion criteria are all the patients diagnosed with acute appendicitis of age 15 to 60 years, and all the patients diagnosed with perforated appendix and gangrenous appendix of age 15 to 60 years. Exclusion criteria: patients of age less than 50 years and more than 60 years, patient with appendicular mass, history of alcoholic liver disease, hemolytic disease, and liver disease which associated with hyperbilirubinemia, and patient who have history of GI or hepatobiliary malignancy in the past. My study is conducted in the Department of General Surgery, St. Martha's Hospital, with a study population of 50 patients from August 2020 to December 2021. It is a prospective observational study. Patients admitted in the surgery ward with the diagnosis of acute appendicitis and appendicular perforations were selected. With the routine investigation, liver function test has been sent. Coming to the results of my study, out of 50 patients, more than 50%, that is more than 28 patients lies in the second and third decade of the life. With the male predominance, that is 28 patients were male and 22 patients were female. The total bilirubin in acute appendicitis with a mean of 1.2 with standard deviation of 0.5 is considered, and in acute appendicitis, mean of direct bilirubin is 0.5 with a standard deviation of 0.3. In perforated appendix, the mean total bilirubin is 2.2 with a standard deviation of 0.3, and direct bilirubin of 0.9 mg per dl with a standard deviation of 0.4 is considered. Clinically, 40 patients are diagnosed with acute appendicitis, and by intraoperative diagnosis, 38 patients diagnosed with acute appendicitis and 9 patients diagnosed as perforated appendix. By histopathological report, 34 patients diagnosed with acute appendicitis, 9 patients diagnosed with perforated appendix, and 7 patients are diagnosed as recurrent appendicitis. Now, we are like to correlate the elevated serum bilirubin in acute appendicitis and the clinical diagnosis. Out of 80% patients had elevated serum bilirubin of more than 1.2 mg per dl in a patient diagnosed as acute appendicitis by clinical examination. By correlating the hyperbilirubinemia in acute appendicitis and peroperative findings, 68%, that is 34 patients diagnosed with acute appendicitis by intraoperative diagnosis had elevated bilirubin level of more than 1.2, and 32%, that is 16 patients had normal serum bilirubin level. Out of 9 patients diagnosed as perforated appendix by intraoperative findings had elevated bilirubin of more than 2.2 mg per dl. That is, out of all the 9 patients had significant elevation in the serum bilirubin level. Coming to the correlation between acute appendicitis and histopathological examination, 72% of the patient, that is 36 patients who diagnosed as acute appendicitis by histopathological examination had elevated serum bilirubin of more than 1.2 mg per dl, and 9 patients who diagnosed as perforated appendix, and all the 9 patients had significant elevated serum bilirubin level of more than 2 mg per dl, and only 33% patients who diagnosed as recurrent appendicitis by histopathological examination had an elevated serum bilirubin level. Coming to the validity of hyperbilirubinemia in acute appendicitis, 72% patients had a sensitivity rate for acute appendicitis with a positive predictive value of 82% and diagnostic accuracy of 68%. Coming to the validity of hyperbilirubinemia in appendicular perforation, which sensitivity of this test is 100% with a negative predictive value of 100% with a diagnostic accuracy of 44%. Coming to the discussion, the peak incidence is second to third decade of life. It is relatively rare in infants and becomes increasingly common in childhood and early adult life. The incidence of appendicitis is equal in males and females before puberty. The male and female ratio is 3:2 at the age of 25.1 year. The lifetime rate of appendicectomy is 12% for men, 25% for women, with approximately 7% of all people undergoing appendicectomy for acute appendicitis during their lifetime. In my study, out of 50 patients, 56% were male and 44% were female. The mean age group is 23.1 plus or minus 11.99 years. And in the male age group, the mean is 24 plus or minus 11.93 years, with the female 23 plus 1 plus or minus 11.9 years. Hyperbilirubinemia in our study was found 40 patients, that is 80% at elevated serum bilirubin level and 20% at normal serum bilirubin level. The mean serum bilirubin in 50 patients was 1.2 mg per dl, and direct bilirubin mean value was 1 plus or minus 0.7 mg per dl. For appendicular perforation, the mean total serum bilirubin was 2 mg per dl. Out of 50 patients, only 25 patients, that is 50% patients, had elevated total leukocyte count. With this, I would like to conclude, serum bilirubin level appears to be a promising laboratory marker for diagnosing acute appendicitis. Patients having clinical signs and symptoms of appendicitis with significant hyperbilirubinemia should be identified as higher probability of appendicular perforation. My take-home message is, patients with signs and symptoms of acute appendicitis with serum bilirubin of more than 2 mg per dl in a place where there is a lack of radiological investigations, we can consider it as appendicular perforation or acute appendicitis. These are my references. Thank you.
It was open for discussion.
Can I comment on this, please?
Sir.
Sir.
Please tell me, what is the mechanism of hyperbilirubinemia in complicated appendicitis?
Sir, whenever there is acute appendicitis, there will be a bacteremia through the inferior mesenteric vein. This bacteremia invades the...
We physicians call it as pyeloplasty. Is it surprising? And how many of your cases you diagnosed it as appendicitis based only on serum bilirubin findings?
More than 40 means 80% of the patients had elevated bilirubin levels, sir.
And when you commented on serum bilirubin, you have not commented on SGOT, SGPT, serum alkaline phosphatase, and past history of any liver illness, including congenital hyperbilirubinemias. Be careful about it.
That exclusion criteria,
also, please be careful. You could have a parallel infection of hepatitis E, hepatitis A. And if you are in a hurry to operate on a patient who has got an occult hepatitis E, your morbidity, mortality will increase. Please be aware of this.
Okay.
Dr. Karthik, Dr. Niranjan here. See, hyperbilirubinemia is a marker of sepsis. It can go up in the case of acute calculous cholecystitis also, acalculous cholecystitis also. So, in your conclusion, you said any patient where the radiological investigation is not available, hyperbilirubinemia will invariably indicate acute appendicitis. I think that's a very broad statement, which probably
with the
is not
signs
correct.
and symptoms of acute, appendicular signs and symptoms, we can consider this ventral score.
Sometimes the
clinical
appendix
diagnosis
can also have a pain higher up. It need not be only in RIF. So you have to be very specific. Okay. So at least a minimum of ultrasound should be done before you just straight away take them up.
Okay, sir.
Okay.
Okay, sir.
So it's a supportive marker, no doubt. But any sepsis will lead to hyperbilirubinemia.
Yes, sir.
Thank you, Dr. Karthik. I think we are short of time. We'll go to the last paper.
Thank you so much, very much.
As you know, again, one of the commonest topic discussion of cholecystitis, when to operate, not to operate. So Dr. Sriram will be talking about early versus individual cholecystectomy and acute cholecystitis. Time frame will tell you. Over to you, Dr. Sriram.
Good evening, everyone. Before I start, I would like to thank Surgical Society of Bangalore, President and Secretary, and St. Martha's Bangalore General Surgery Department for providing me such an opportunity to provide the paper in Surgical Society of Bangalore. So, on to my paper. My paper is a comparative study between an early versus delayed laparoscopic cholecystectomy for acute calculous cholecystitis, patients presenting beyond 72 hours and within 7 days of the symptom. It intro. Acute calculous cholecystitis is encountered in approximately 1/5 of all admissions with gallbladder diseases. Although laparoscopic cholecystectomy is the most commonly preferred treatment method, controversies about the timing of laparoscopic cholecystectomy in acute calculous cholecystitis still continues. A school of different thoughts where laparoscopic cholecystectomy was considered contraindicated for acute calculous cholecystitis presenting beyond 72 hours. Cholecystectomy was recommended for patients after a 4 to 6 weeks interval of medical treatment and conservative approach. The interval period was said to be necessary for resolution of acute inflammation and safe cholecystectomy. Some of the papers, for example, they have compared an early and interval laparoscopic cholecystectomy. For example, one of this paper over here, they have done a series of study to know which is the appropriate time for go ahead with the laparoscopic cholecystectomy. But still, they have concluded that rather than interval, early laparoscopic cholecystectomy is preferable, but they have not exactly said which timing is preferable to go ahead with the surgery. And one more paper, they have compared an laparoscopic cholecystectomy versus delayed cholecystectomy for 24 hours of case presentation. But so far, none of the papers have presented that they have compared the presentations in the same duration for early and delayed laparoscopic cholecystectomy. So here, I go with the aim of this prospective randomized study to evaluate the safety and feasibility of early laparoscopic cholecystectomy for acute calculous cholecystitis presenting beyond 72 hours and within 7 days in comparison with the delayed laparoscopic cholecystectomy. It's a prospective randomized control study conducted in Department of General Surgery in Mathas Hospital, study period of 2021 of June to June. So criteria which are included as the 18 to 60 years of age group. The patients who are diagnosed with acute calculous cholecystitis, the definition comes as follows, and applying to ASA of grade 1 and 2. Exclusion criteria we have considered as ASA grade more than 3, and patients present to us as pancreatitis with common bile duct stones. And the patients who are presented within 72 hours of symptoms have also been excluded. And patient present with JB polyps along with tuberculosis is excluded. So diagnosis of acute calculous cholecystitis, which we have defined, was based on an Tokyo classification where they say the acute upper abdominal pain with tenderness under the right costal margin, that is Murphy sign, and patient having fever more than 7.5 degrees Celsius, and leukocytosis total counts of more than 11,000, and the most important ultrasonographic finding showing a GB wall thickness of more than 4 mm with pericholecystic fluid of standing. So two groups. So here we define the two of my groups, where one group being the early group and another being the delayed group. So we have 20 patients in each group present to us with acute calculous cholecystitis beyond 72 hours and within 7 days. Both the groups having the same timing of presentation and they have same number of case studies. So for early group, we have went on to do early laparoscopic cholecystectomy as and when they presented to us. For the delayed group, we have went on to do a delayed laparoscopic cholecystectomy after an interval period of conservative management beyond 4 to 6 weeks. The procedure that we have followed was that laparoscopic cholecystectomy was performed using the standard 4-put technique, and post-operatively patients were allowed oral intake 6 to 12 hours after surgery, but they had no nausea or vomiting. Pain relief was obtained by intramuscular analgesics, which was changed to oral medication once patient was allowed orally. The patient was discharged once the patient was febrile and taken diet orally. So the analysis comes here. Pre-operatively, we analyze the mean age group, the sex predilections, and the duration of acute symptoms which they presented to us, and the number of repeated admissions that they had, which means the number of admissions totally they had. Prior, they went on to this cholecystectomy surgery and previous abdominal surgery. So here, in pre-op analysis, the significance comes when there is repeated admissions. So in the early cholecystectomy group, we almost had 0 repeated admissions before the surgery. In case of delayed cholecystectomy group, we almost had 6 admissions before they went on did an interval cholecystectomy, which makes the p-value significance of less than 0.05. The intraop analysis, the things that we have considered into consideration for intraoperative was dense GB adhesions and the emphymatous GB and leukocyl of the GB, and the duration, which as many literature says significance comes in the duration. So duration and the conversion, bile duct injury and hemorrhage. To our surprise, there was not much difference was noticed between the early group and the delayed group in the intraoperative analysis, where the dense GB adhesions were almost seen 9 and 7, and empyema GB were early cholecystectomy patients present where we went on to do an early surgery, and mucosal GB was seen in 10 cases in delayed cholecystectomy. Duration was almost same except the 3 minutes difference between the early and the delayed group. The conversion, as all the literature says, we also had a conversion rate of slightly 1 more than the delayed cholecystectomy group, where early had 3 and delayed had 2.
Must have become resistant by now.
there was a bile duct injury in direct cholecystectomy group, and there's an excessive hemorrhage, probably abnormal cystic artery in the early group. So this is one of the cases where we had a gangrenous GB, and the patient presented to us 4 days with the symptoms, and we evaluated the patient, went ahead at the early laparoscopic cholecystectomy group. The patient belonged to the early group. So the surgery was successful, and we were able to complete surgery without any complications. This is another case where the patient presented to us 5th day with acute calculous cholecystitis, and we went on to do the early cholecystectomy again, where like the dense adhesions and inflammation they said, which was a tough job to do the surgery, actually enabled us here in creating a plane around the GB and inserting the GB easily. This is one of the cases where delayed group where there were test momentary adhesions, making it difficult for us to do the surgery. Post-operative analysis. The significance of my paper comes in the post-operative analysis where post-operative hospital stay, which is the mean number of days stay, in early group was 3 days and delayed group was 2 days. This was slightly closer to significant, but it's not yet significant. The significance comes in the total hospital stay. That is the number of days the patient had to stay, including the repeated admissions, all the days the patient has to undergo surgery with the mean days. In the early group was very less, which is 5, and the delayed group happened to be 9, which makes the p-value very significant, is less than 0.05. While we almost had in both the groups 1 and 1, and there was some post-op pyrexia in 2 patients in the early group, and surgical site infection was noted in both the groups 3 out of 3 patients. So come to the results of my paper. The mean age of both groups are almost the same. There was no repeat admissions in the early group, whereas 6 got readmitted in the delayed group. The intraoperative findings were almost comparable in both groups with 3 converted in the early group. The duration of surgery was almost same in both the groups. There was a really significant difference in the total hospital stay, including all the admissions, the delayed being very high. The main reason for conversion here is that the early group we had unclear carotid and triangle anatomy and hemorrhage. As delayed group there was a bile duct injury and difficult carotid anatomy. To come to the discussion, the experience from the study supports the belief that the inflammation associated with the acute calculous cholecystitis actually creates an edematous plane around the gallbladder, thus facilitating its dissection from the surrounding structures. Waiting for the inflamed gallbladder to cool down allows maturation of the surrounding inflammation and result in organization of the adhesions, leading to scarring and contraction, which makes the dissection more difficult. The common approach is to be for management of acute calculous cholecystitis present in beyond 72 hours, defining the golden 72 hours, consists of an initial control of inflammation followed by interval cholecystectomy of a period of 4 to 6 weeks. Arguments that were made against early laparoscopic cholecystectomy includes a high conversion rate and complications. However, there is an increased risk of gallstone-related pancreatitis morbidity during the waiting period for cholecystectomy. To conclude, morbidity of laparoscopic cholecystectomy for patients with acute calculous cholecystitis is not reduced by a period of initial conservative treatment. For surgeons with adequate experience, the optimal timing of laparoscopic cholecystectomy for treatment of acute calculous cholecystitis can be considered within 7 days of admission. Early laparoscopic cholecystectomy is safe and feasible, offering the additional benefit of a shorter hospital stay. Hence, early laparoscopic cholecystectomy can be considered for patients presenting beyond 72 hours within 7 days as acute calculous cholecystitis with high threshold for conversion. Thank you.
Thank you, Dr. Sriram. The paper is open for discussion.
Yeah, Dr. Sriram, nice message. This is Dr. Niranjan. Just wanted to know whether it's a retrospective study or a prospective study.
It was a prospective study, sir.
Then
when
how
you
did
have a
categorize
patient, when you have a patient of biliary pancreatitis,
Sir,
Yes, sir.
when you have
hello. Yeah.
Yes, sir. Yes, sir.
So I was asking, how did you categorize them into 2 groups? What was the criteria?
Sir, it was an every
It was
odd
a
person we
prospective
put in the
study.
early groups. Yes, sir. Very odd person we put in the early group, every even person we put in the late groups.
Was the consent
It's a randomized
taken
study
and
also.
the pros and was the consent taken and pros and cons explained to the patient
Explained
and
to the
ethical
patient,
committee?
Yes, sir. It was
Ethical
explained.
committee approval was sought.
Yes, sir.
when you have a patient of biliary pancreatitis,
Yes, sir.
you have conservatively managed, and in your experience, do they come with a second attack of severe pancreatitis?
Sir, actually, I have excluded the patients who presented to us with biliary
No,
pancreatitis.
it's a general question. I am not asking you.
Yes, sir. Come again, sir. Sorry.
Because you deal with gallbladder surgeries and this thing more than us as general physicians and gastroenterologists.
Yes, sir.
How bad is the second episode of pancreatitis?
So they always present slightly severe than what they present to us previously.
Do you encounter in your practice?
Yes, sir. We do encounter in our practice, sir.
Now, what is the safe time between ERCP and gallbladder surgery?
The safe time between ERCP and gallbladder surgery would be the earlier the better.
Earlier the better, or
Yes,
you
sir.
want to wait? Because there
No,
are a
sir.
lot of surgeons who do it on the same day. Do you recommend that or no?
Sir, I would recommend as early as possible be better.
Earlier means how early?
Sir, preferably within the same sitting of ERCP, sir.
Our recommendation is you wait. Don't be in a hurry. At least give a gap of about 72 hours before you take him up for a gallbladder surgery. Because when there is a morbidity and mortality, we do not know whether it is because of ERCP procedure or your surgery.
Yes, sir. Yes, sir.
Point well taken, Doctor. So any more questions, sir? We are running out late. This should be our last.
So I have a question to Dr. Sriram and Dr. Kapil here.
Yes, sir. Yes, doctor.
Yeah, you've touched upon the Tokyo guidelines, but there is a classification. You grade them as grade 1, 2, and 3. Have you factored into your study before randomizing them? Because that will change all the results. It will have an important bearing.
Sir, grading of what, sir?
The grading of severity of this cholecystitis,
Sir.
as grade 1 and 2 and 3. Have you done that? Have you included that?
No, sir. Because I have not done based on gradings.
So what if you're doing grade 1 colis immediately and pushing all grade 3 into interval, then your results will be skewed. Do you understand the point?
Yes, sir.
That is very vital for to come up with the study. But the latest study, which is there, latest RCT and meta-analysis says that there is no difference in the approach in an advanced center. So that is the catch point. If you're sending a message, it should be an advanced center and the surgeon should be very skilled. We from Institute of Gastroenterology, we routinely do cholecystectomy acute, even if it's beyond 72 hours. That is first point.
Yes.
Second point, just to answer the question of when do you do a lap chole after ERCP, I think it depends on the severity, sir. That would be my answer one. And second thing would be the CPD cannulation. If we have not done, the patient is doing fine, then we would post the patient for a lap chole the very next day. That would be my answer for that question which the sir has asked.
Apart from that, he was okay when I saw him. Probably 1 hour back. We had repeat Madila. Probably they will repeat it tomorrow.
Somebody is talking over the
I think Dr. Niranjan.
Surgery. Only thing he was probably withdrawal. He's talking irrelevant. Vital stable. Sorry. ನನ್ನ ಕಡೆಯಿಂದ probably 48 hours ಅಲ್ಲಿ
Anyway, thank you for this. Yeah, the papers are all come to an end. I'd like to thank everyone colleagues and the panelists, and also our superior of this hospital, Dr. Senior Doctor, Dr. AK, and all of the PGs and other doctors. And I'd like to thank all the judges for the videos, especially. It's a nice job done. Thanks, sir. And with this, we also thank Dr. Kumar and we hand over to the announcement. Sir, before that, a small presentation for photography changes. President Dr. Sampath. Photo. Thank you, sir. Thank you, sir. Accepted. Thank you, sir. Thank you, sir. Now I'll take. Now I'll take you to back to Dr. Prem for further announcement and. You change one.
So we have a few announcements to make. The next monthly clinical meet will be hosted by Clinical Hospital and Medical College. That is scheduled on 16th of February. There is a special announcement that we have requested. Just request Mr. President to have the special announcement.
Hello, everybody. Please note, KSC ASI elections are announced. The dates is from February 1st to 10th. It is an online voting. The voting link will be shared to everybody in the WhatsApp. I request each and everybody, without forgetting, please vote. And there's a special announcement from me and from our SSB. This is to say that our doctor, who everybody knows him, Dr. H.V. Sriram from Bangalore, standing for President-elect. And I don't have to tell you what to do. He is for our Surgical Society Bangalore, our pride this thing. So I think everybody has to vote our own man for this prestigious position. Please do the needful. Thank you very much.
Thank you, sir. Coming to the next announcement, which is most awaited, that is announcement of the winners. I request the president to do the honors of announcing the winners of today's poster and paper session.
Best poster award goes to Dr. Vandana. This is for adrenal adenoma, defying the basics. Vandana, please come.
Good, congratulations.
अधिनायक जय हे जनगण मन अधिनायक जय हे भारत भाग्य विधाता पंजाब सिंध गुजरात मराठा द्राविड उत्कल बंगा विंध्य हिमाचल यमुना गंगा उच्चल जलधि तरंगा तव शुभ नामे जागे तव शुभ आशीष मांगे गाहे तव जय गाथा जन गण मंगलदायक जय हे भारत भाग्य विधाता जय हे जय हे जय हे जय 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 हे